First of all, thank you very much for the invitation. I would be much more delighted if finally this could be in present and to see each other, to hug each other, and of course to be together again. But I hope this is going to be real in a very short time. Thank you very much for taking me into consideration for this topic, which, as you might guess, this is one of my favorites. And overall, all channelopathies, I think they are really interesting, and is this growing topic that we really love. So to go into the topic, I would like to make a first introduction in terms of Brugada syndrome. As now, when we think about Brugada syndrome, we think about adults, because we all know that Brugada syndrome is a male around 40 years of age, which is like our target to study. But I would like to remember that the first patient that was described with Brugada syndrome, it was in 1986, and it was a child. And the first abstract published by Pedro and Josep in 1991, from the four first patients, two were children. And finally, the JACC publication in 92, where the disease was described as itself, 3 out of 8 patients were children. And why does it happen? This is a picture of the first patient. And why these things happen? Well, because when we describe a new disease or a new manifestation of a disease, of course, we see the worst case scenario. We see the situation which is the worst phenotype. So, of course, the worst phenotype does not appear at the age of 40. The first phenotype appears at this age, at childhood, because it's when the disease itself is so severe that it has, at the first month, sometimes even in fetal life, presents its arrhythmogenic form. So it's very important to understand which are the signs and symptoms of Brugada syndrome in children, mainly because we have to be aware, even though that as National Reference Center in Barcelona, that concerning channelopathies and arrhythmias, we receive very severe patients or very difficult patients. It's true that we need to keep our eyes open in order to promptly diagnose children with Brugada syndrome. But it's very important from pediatric point of view to teach our adult cardiologists that even though Brugada is much more common in a 40-year-old male, it's true that women are also affected, and it's true that children are also affected. And it's very important to rule out which children might be at risk. I've heard, or I've even received patients who were told, the family was told, that there was no need to check the children before the age of, let's say, 15. And as you will see, there are certain situations that certain conditions that the disease appears or gives symptoms at a very early age. We have to know that at pediatric times or age, 70% of the patients, of course, are asymptomatic, and that's the way we receive them. 1/3 will be genetically positive, but 5% will have a spontaneous diagnostic of the ECG. These are numbers from our series, and that's very important because those 5% are at very high risk, because at a very early age, they already present with a diagnostic ECG, but meaning that the disease is there, that the disease is pushing hard, and this child might be at risk because it's true that those with abnormal ECG at basal ECG will be at a higher risk, of course. Less than 2% of the children will need an ICD. That's very important, but there's no need to put an ICD because you have a Brugada or you are genetically positive to Brugada, or you have a spontaneous ECG with Brugada. You don't need an ICD for that. There are other conditions. But as I always say to my patients, the best prevention of Brugada, problems related to Brugada, are diagnostic. So children that, in general, children that are diagnosed have much less risk than those that just walk around life without a diagnosis, because many of the problems come related to receiving drugs or not controlling fever. So it's very important to take into account that diagnostic of Brugada does not mean ICD. Spontaneous ECG, type 1 ECG, does not mean ICD. And that has to be clear in mind from the very beginning. Once again, fever, it's the most important thing in childhood with Brugada syndrome. And fever can manifest in two different ways, which is febrile syncope and febrile seizure. Febrile seizure, it's very common in children. And it's very important that we have that in mind, that even though it's we can consider it nothing, febrile seizure, it's so common that we don't even admit patients in the hospital for a febrile seizure, if it's first seizure or whatever. It's very important to ask for family history of syncopes, family history of febrile syncopes, or even pacemakers or defibrillators or so on. So have that in mind, that fever and childhood in Brugada are very important. Why? Well, because fever can show us this pattern change, and that's very important because, in fact, fever is a way that would help us to diagnose many patients with Brugada syndrome. Why does it happen? Because in some cases, or in 1/3 of the cases, there are arrhythmia. The disease is related to sodium channel. Sodium channel is it's temperature dependent ion channel that would change its configuration depending on which is the temperature. So if you have fever and you have a diseased or an ill sodium channel, when you have fever, that disease will increase its effect. So you will manifest the pattern, and you will be at a higher risk during febrile periods. So, and this is one other way of presentation, which is febrile seizures. So this is a beautiful report showing that febrile seizure can help us in masking Brugada syndrome in children. That's why it's so important to just take the benefit of the febrile situation to make an ECG. That's what we did in our hospital. We started a study that every single febrile seizure that was was entering the emergency department in our hospital was having an ECG after seizing, of course. Otherwise, we would not see anything. And so we started that in January 3 years ago. And so we said, okay, we're going to do that for 2 years. So we recruited many patients with many ECGs. And okay, we were trying to convince the people in the emergency department to do those ECGs because, of course, you know, in winter you have many patients in the ER. They come and they are overwhelmed with work, and then they have to explain this to the parents and to do an ECG. So it takes time, and to convince them it was time consuming. But everything came normal, and it was a little bit desperate to try to convince to keep on going winter after winter to do those ECGs. But the very last day of the study, when we were closing, that was 31st of May, I think, we were closing the study. The very last night, this patient came, we did an ECG, and it was very positive, you know, very clear type 1 ECG pattern for Brugada syndrome. So just for that case that we could diagnose, and then we did family screening, and we saw that 3 other patients carrying Brugada syndrome and the father carrying Brugada syndrome and so on. And they were an asymptomatic family. But that took us the opportunity to diagnose this family. So it's so important to take the benefit of the fever to do that. So, but it's true that many of our patients, we diagnose them because they come from family screening, or some of them because they have had an ECG for sport or for whatever reason, and there is some abnormality that pushes us to do a provocative test. Of course, febrile seizure or febrile syncope as it's another way of presentation. And very few cases come with a supraventricular tachycardia, ventricular tachycardia, or even electrical storm. And some of them, unfortunately, first manifestation of the disease can be sudden death. Well, how do we perform family screening? Or what is our protocol? Well, we do when daddy is carrying a Brugada syndrome. We do an ECG from birth, okay, and we do annual basal ECGs to the children, okay, every year, and we give them a letter that I will show now, trying to obtain an ECG during fever. And of course, if daddy has a positive genetic test, we perform genetic tests to the children. Just to remember that only 25% of the patients with Brugada syndrome will have a genetic test positive. So not having a positive genetic test does not mean you don't have Brugada. And of course, there's no sense on doing genetics in a child if the daddy it's genetic negative, okay? So when we have doubts, when for example, in a basal ECG, we have doubts. Sorry, I did not mention that we also perform, this is the way we put the electrodes on the chest to take the most benefit of, to take the profit of the position of these electrodes to see the right precordial leads. We put B1 and B2 in the first intercostal space, B3 and B4 in the second intercostal space, and B5 and B6 in the fourth intercostal space. Why? Why do we do that? Because we know that the anatomic substrate for Brugada syndrome is the right outflow tract, and if we want to take the most of the ECG, we would put the electrodes just all along the right outflow tract, so we will have much more information on that. Okay, when do we perform Ashmelin test or drug-provoking test, either flecainide, Ashmelin, procainamide? Ashmelin, it's the best option. It's the safer from our experience, and that was what in 2014, Great Ormond Street published. They consider it was safe. A little bit different from what the series in Brussels published the same year, that were Ashmelin tests performed in children. They had 4 serious events. For us, before 2018, we were performing flecainide because in Spain we don't have Ashmelin, and we were performing a flecainide test. And of course, there were some mild side effects from flecainide test, like photopsies. And it's very important that we tell the patient that he's going to either feel warm sensation in the pelvic area, in the genitalia area, that may see a little bit of photopsies, and even flavor, like metallic flavor feeling. So it's very important to tell that to the patients, because otherwise they get nervous and then you don't see the baseline very well. The thing is that because of this last complication, we had one electromechanical dissociation, which is this one. We were having electric signs, but no heart movement. That we did all the bureaucratic and administrative workout to make sure that the Ministry of Health would authorize us to use ashmalin. So now we import ashmalin from Germany, and all our tests are performed in ashmalin directly, no flecainide, no previous flecainide. So overall, since now we've performed more than 300 tests, and why we were performing them? Because either in 7 cases were aborted sudden death that we wanted to rule out Brugada, because we had 28 febrile syncopes, and we wanted to rule out Brugada. We had weird supraventricular arrhythmias and dysfunction of the conduction symptoms. And of course, there is an important part from abnormal ECGs, but of course, the biggest part is family screening. So in our case, and this could be an option for discussion for 3 hours, but when we have a positive either flecainide or ashmalin test, we perform EP study for those symptomatic children. And we've done a clinical study implanting subcutaneous Holter in those positive patients. Why we do that? The idea is that when a child is diagnosed of Brugada, every single symptom he would have in his poverty or life is going to be related to Brugada. Okay, so if he just wakes up in the morning and or he wakes up from the sofa and he gets a little bit dizzy or has a little bit weird head, and has a syncope or just maybe a pre-syncope, someone will tell, oh, this is related to Brugada, you need an ICD. Okay, and that's very common. You know, poverty gives you a lot of dizziness and vasovagal symptomatology, and that's not necessarily ventricular tachycardia. But for those children, it was very common they would end up with an ICD just because they just got dizziness, and I was receiving them as a second or third opinion, and what to do with that already implanted ICD there. Of course, no one is going to take that ICD out of their body, but it's very important to decide when to implant. And that's why we think that subcutaneous Holter for those patients are very necessary in order to avoid unnecessary ICDs in those children. So from our series, only 2 had a positive EP study, and that's important to know that the ratio is very, very low. So it's very important that what means positive EP study, that you are high risk, that's very important, that in children, normally having Brugada, it's not that risky. So that's our speech towards the family is that it's not the end of the life. Okay, it's just Brugada. Just take care of not taking some medications that should be avoided and a strict control of fever. That's it. And that's what we say. And why we are so in panic about devices in children? Well, mainly because sometimes the size is difficult. This is one patient. This one. Okay, this is one of our nurses. Of course, type of devices, they are not ready for children. Output energies, for example, for subcutaneous devices are difficult to manage, or entirely subcutaneous devices, you cannot graduate the output energy. We need to do weird things to implant devices in children. And we still perform the fibrillation test when it's not a big pediatric patient, because we think that we need to put as low defibrillation threshold as possible for them. Okay, sometimes, implantations can be so that difficult or that nicely performed, like engineering inside of children's bodies. So, which is the follow-up? We do this modified 12-lead ECG yearly. We do ECG while fever. Once again, this is the letter we give the family so they can go to any emergency department. They don't need to come to our hospital. So they have this ECG done. Imagine that you are in the emergency department and you are seeing one of those 10,000 children that have fever, and someone says, oh, I want an ECG for my child. Give them a letter and you'll make their life much easier. And one thing that has helped us a lot is to put we don't need nobody to interpret that ECG. We will do that because we've seen that in some areas that are not used to children, they are a little bit scared of saying, oh, this is a normal ECG, so they don't perform the ECG. So we say, okay, we don't need interpretation, just send us a photo or a scan of the ECG and we will do that. Okay, it's very important that they are very updated on the Brugada drug list, so to make sure that they don't receive any of the drugs they are there. And of course, if any symptom of dizziness, palpitations, syncope, of course, they have to go to ER. So this is the follow-up for our series of patients. We have had no sudden death so far. Okay, I hope it keeps like that. And we have 13 children with ICDs, 5 of them having received appropriate shocks. And we have so far, and that's another point, have received none of them have received inappropriate shocks. That's very important. But we know that we are going to have patients with an inappropriate shocks because it's common in children. Okay, 5 of our children are with quinidine. Quinidine will help in some patients to control the rate of arrhythmias, and that's important. And 2 of them, even though they have Brugada, they don't need ICD so far. It's a form of sick sinus syndrome and conduction disease, like left Lenegre disease. So they need a pacemaker. So far, once again, fever, it's the most important precipitating factor for arrhythmias and bad prognosis in Brugada. And we know that we have more problems if we have a spontaneous type 1 ECG. So let's say, take away the drugs that block the sodium channel, control fever, and with normal basal ECG, things are going to be okay. And that's the overall idea. In pediatrics, in our series, we see no gender differences. That's normal. I mean, if we know that testosterone is related to Brugada before puberty, there are no differences or mild differences in testosterone levels. So it's normal that we see no differences. And to finish, we just share, I want to share this case. This is the worst case scenario in our situation. This is a child at 3 years of age came into the ER because the daddy said that he heard his heart slow. And he went to emergency department and he had this ECG, which we only see just a little PR, prolongation of the PR, that's it. But we put a Holter. In fact, the emergency department did not believe much the father. And but there was a free Holter there, so we put it. And surprisingly, we saw this PR enlargement, some blocks, some complete AV blocks, and finally a complete AV block in this child. So we saw that it was a sinus node, AV node dysfunction. At that point, we said, oh, that might be a presentation for Brugada, and we performed a flecainide test, which was negative by that time, but we put him a pacemaker because he had blocks and intermittent blocks. So everything went well, and we received his genetics, that was in 2015, and he got this genetic variant in sodium channel, which was not reported in literature. And in fact, there were not bad number of presentation of this variant in general population. So we said, okay, I don't know. We did not know much. Mommy was a gene carrier of the same variation, same variant. And in fact, she was asymptomatic and she had a negative flecainide test. So we say, okay, this child needs a pacemaker, but that's it. And it's not a Brugada so far. Anyway, so 3 years later, he was carrying a micro-knee from St. Jude Medical, which, as you may know, has no registries of electrograms. So when 3 years later he came with a febrile syncope, we did not know what happened. We saw that the pacemaker was working well, but we did not know what happened. But that was his ECG, as you may see This is there is no P waves here, and it looks like flutter. And we put him in the EP lab, and of course it was a flutter. That are the signs that we have from the atrium. This is a 2-to-1 flutter, and that's the image of the pacemaker, the atrial catheter for the EP study, and the ablation catheter. And we did the ablation of the flutter, and suddenly this is once again the atrium. This is the ablation catheter, and after just cutting the flutter, we had silent atrium. Okay, no atrium function or electrical function here. We paced from the atrium, and there was AV conduction, so it was silent atrium, and that was the pacing from the atrium from the ablation catheter, and we had AV conduction. And so we said, oh, this looks like Brugada. We have all these conduction diseases. So that's when we started with flecainide test, again, 3 years after those. That was 3 years of age for flecainide, and this is 6 years of age, the second flecainide test. And we could see that was this pattern. But short after, he started what I showed you before, this electromechanical dissociation. Of course, this was in a very severe case of Brugada. We went with chest massage, cardiac massage, for 1 hour until the flecainide came out. And he recovered after that. He recovered without neurological sequela. But as you may imagine, that was very difficult for us. So that's why we changed to Ashmelin, that at least has a much shorter life. So we implanted ICD to this child. He had many ventricular tachycardias during his life. We added quinidine. We increased doses of quinidine, even though he was having many types of arrhythmias. And even we added some nadolol to try to control that. We could control a little bit more the arrhythmias, but after that we were much more experienced with our experience with Brugada substrate ablation in adults. We decided to perform an ablation, an ablation of the epicardial substrate, right ventricle outflow tract substrate, in this child at the age of 9. This is the endomap when we see no abnormalities in the endocardic map of the right ventricle, but for the epicardial, we would see that there were 2 areas. When giving Ashmelin, those 2 areas were different from the rest. And we did the ablation of this area here, burning, trying to get rid of those areas. And finally, what we were getting is this shape, which is kind of a weird pattern on Brugada. And finally, we got this is paste and non-paste after the ablation. And after that, we were really confident that even with a little bit of quinidine, and that's it, he's getting much better without arrhythmia so far. He's 14 now. And that has been like our nightmare, but it's very important to see that this child has evolved a long life, and that's a very important point in Brugada patients. So as a conclusion, our protocol is annual ECG with fever, drug challenge when they get into puberty. I haven't gone too much into detail on that. If we have to perform drug challenge before puberty and it's negative, we repeat it after puberty. But if ECG is normal, no symptoms, we wait until puberty it's already established. We use quinidine and ICDs if needed, only if needed. We suggest a strict fever control, Brugada drugs list everywhere, then every time they have to receive anything. Of course, it's very important to take into consideration that syncopes can mask all type of diseases, that diseases change a long time as their hormones and the situation and disease. It's an evoluting disease. That children are weird. When we see diseases in children, it's the more severe cases, and of course that's important to take into considerations. And we have new options in the horizon, and it's important to use them just only when we are in very severe cases. We don't know the long-term benefits or complications of those techniques, but when we are in a no exit road, we need to do special things, of course, and that's it. And thank you the organization once again to having given me the opportunity to be here and to share this Sunday morning with you.
Thank you very much, Georgia. That was truly comprehensive. I think it is very important, the message, all of your messages, but when we have a child with febrile syncope, we should perform an ECG, yes, in order to identify whether there is any sign of Brugada syndrome, but also the fact that disease can progress with time, etc. Do we have any questions from the audience or my co-chairman?
Congratulations, Georgia. The question is also the false positive ECGs, that the child ECG pattern having an incomplete right bundle block like RSR confuses the adult cardiologist, and we, the pediatric cardiologists, we are overwhelmed with referrals for suspected Brugada, and they insist to have an IMALIN test. What would you comment on this? Do you have the same experience? Thank you.
Thank you. That's a very interesting and common situation. We have the problem that we receive many ECGs, and just having this incomplete right branch block, which is present in more than 30% of children, normal children. Of course, we cannot perform IMALIN test in 30% of the children. This is nonsense. I really think that it's very important to talk about family, of course, family history, but also to see if it's just randal branch block. If we cross a line through the whole leads and we see that there is no ST segment elevation, there's no need to perform an IMALIN test. ST segment elevation, it's the difference, and that's important. Of course, if I would have a prolonged PR interval, an incomplete randal branch block, and a doubt on the ST segment, I would perform IMALIN test, because these are already two signs of conduction disease. Okay, prolonged PR interval, incomplete bundle branch block, but just incomplete bundle branch block, I would not do an IMALIN test.
Thank you so much. Your topic deserves a whole day of Congress, I think. Thank you.
Okay. Then Dr. Ephremidis, would you like to comment or add something?
Yes. Thank you very much for your presentation. One question about the need for EP study in these patients. Can you clarify the indication? You mentioned that you perform EP study in every case with a symptom, with a Brugada sign, Brugada ECG, and every symptom. That means dizziness.
Of course, if we have a patient with Brugada syndrome and has dizziness, syncope, we perform EP study. Of course, we have to go further for that symptom to make sure that this patient is not at risk, and we would implant a subcutaneous holder as well. For those patients with a pathological basal ECG, so a spontaneous type 1 or maybe a type 2 with symptoms of palpitation. It's very common to see supraventricular tachycardia in children with Brugada syndrome. So, and some of these supraventricular tachycardias might be accessory pathways or flutter, and it's important to get rid of those as well. So we perform EP study on them, and if we find any substrate for supraventricular tachycardia, we ablate them.
And in case that you have a patient with type 1 ECG of Brugada, but without any symptom, do you perform also EP study?
Yes. I mean, the only way we can see for spontaneous type 1, it's a high-risk situation, and we perform EP study. Most of them, only 2 children have turned positive. All of the rest, we put subcutaneous Holter, because I think spontaneous ECG, it's one of the risky situations. And any type of symptom that this child would have in his life, we need to know if it has been ventricular arrhythmia, so he deserves an ICD, or just dizziness or vasovagal. So it's important to make sure that we have that clear, to avoid implanting ICDs, unnecessary ICDs, and to know what's the basis. Because if it's flutter, for example, if it's flutter that provoked a syncope, maybe you don't need to put an ICD, it's just you get rid of the flutter. He will need in the future probably, but at least you control that arrhythmogenic situation at that moment.
Also, one more question. Do you use a combination system? I mean, an algorithm for deciding the ICD implantation? But in the adults, we use also an algorithm that comprises syncope, type 1, atrial fibrillation, family history. Do you use also this algorithm for children?
Okay, I think okay, Shanghai score, you mean, right?
Yeah.
Okay, yeah. Shanghai score, it's not has not been proven for children, and overall, it's syncope, positive EP study, spontaneous type 1 ECG. It's more or less the same, but Shanghai score is not validated in children. We are trying to validate it, but as you know, we have many lower numbers in children, so it's difficult to validate. But it's important to probably overall it's going to be valid, the Shanghai score as well for children.
Okay.
Thank you very much.
Good. Thank you very much indeed. Thank you, Georgia, for being with us, and we hope to see you again in the future. We will have to move on.